And we're now recording, so look, that's great. So tonight we were going to focus our discussion around, you know, some of the issues that are faced in the various hubs, some of the frequently discussed barriers and opportunities. And we wanted to turn it into a sort of more of a positive thing about what are the essentials that we need to get a service up and running. What are the essential considerations to have a viable service? What are our issues that we need to, you know, overcome, and how can we look at ourselves as an ever-growing advocacy group with particularly with our Victorian Department of Health, so that we can continue getting funding for the great work that we do and expand the scope of practice of those of you who are already working in this area, and continue to support you all in a sustainable manner. And our advisory group was just sort of talking about some of our pet peeves, and we thought we'd like to put it into a bit of a presentation, but turn it into a discussion and hopefully come up with some positive outcomes and advocacies. And I have personally some news to share with regard to curriculum changes within the college that I think will be really favourable for helping develop opportunities for training within the hubs. So I thought I would share those things. Louise, we had been talking at the meeting about, you know, some of the experiences you'd had at Bendigo. So I've just prepared some slides. I wondered if you wanted to say anything first, or do you want to chip in as the slides go along? How would over to you, whatever you would like to do.
Yes, I'm very happy just to chip in. I just think it's wonderful to have quite a few GPs here tonight, and I think would be a great opportunity for from a GP perspective to look at how they're faring and what information that perhaps some of the hubs like Gateway and ourselves could discuss, that perhaps are you know, lessons that we've learned from early days. But from a nurse practitioner's point of view, I'm happy to chip in regards to probably more of the broader aspects of running a successful service. So I'm happy just to be guided by you, Patty.
Sure. Sarab, where are we going to have a very short presentation from someone from Sphere?
So Kelly was going to present, but she was occupied today, so she mentioned that she might not be able to visit. So it's fine. We can just move on to the next one.
Oh, okay.
Sorry about that.
That's all right. So Carolyn, it's all Carolyn Mockabell from 1-800. It's all, you are our biggest and most valid database of who's who in terms of providers and who our consumers are, and it's always really good to get a little bit of a roundup from you as to how things are tracking at the moment.
Absolutely, thanks, Patty. So at 1-800 My Options, for those of you that aren't aware, we've had an extension of our service hours. When we were originally funded, we were funded to operate from 10 till 4 Monday to Friday. We've extended the hours to 9 till 5. We're seeing quite a significant increase in calls during due to the extended hours, and it's an average of about 23% more calls every month, and attributable to the extended hours, which is extraordinary. So we're currently sitting around about 100 calls a week. We see very dramatic drops in call numbers when there are particular things happening in COVID land. So as lockdowns occur, when there were a lot of marches and protests happening in the Melbourne CBD, the calls dropped pretty quickly, and they take a little bit of time to come back up again. In terms of our caller demographics, around 17% of our callers currently are rurally located. That's up a little bit the last financial year. It was sitting at around 15%. So it is slowly creeping up, which is fabulous. And I think it's thanks to a lot of the work that the group here has been doing in just promoting sexual and reproductive health and access to services. Around 4% of our callers are under 18, and that's sitting relatively steadily. About between 72 and 75% of our callers are under 9 weeks gestation as well. And that's been really steady throughout the entirety of 1-800 My Options. And I think it's a really important point to raise as well, that most people who are seeking abortion are seeking it very early on in the pregnancy. We're currently sitting at about 4.5% of our callers requesting LARC, and 90% are looking for abortion services. So that, again, the abortion seeking has been pretty steady. LARC is really, really slowly creeping up. Unsure what that's attributable to, but it's good. And I guess the only other thing that we're really seeing that's particularly notable at the moment is a continued trend where we're seeing people at a later gestation than we would prefer to. And I think this is something we've been talking about to the group for quite a while. Our average was normally around 3.5% of our callers, and it creeps up and down a little bit, but our average for 2021 is currently in the sixes, around 6% to 6.5%. And we know that when we're talking to people on the phone, that's often attributable to them simply not taking care of their own health at the moment while they're managing COVID, financial insecurity, and other things like that. Know that when we first started 1-800, the majority of our callers that were presenting in the second trimester had other complexities, that psychosocial complexities such as family violence or significant mental health or drug and alcohol issues. We're not quite seeing the same correlation now. Sometimes I think due to COVID, it is more that life is really getting in the way of people looking after their own health. And yeah, I think that's a pretty brief summary of 1-800, but let me know if you have any questions at all, please. Anita?
Thanks, Carolyn. Sorry, can you just repeat what the increase was for requests for LARCs? And comment on whether more IUDs or implants that in terms of, is one more popular than the other on the phone for women that they're talking about?
Yeah, it's pretty rare that we get a request for Implanon on the phone. And I think that's because people are so aware of it. It's really easily accessible. So we normally have around about 3 to 3.5% of our callers looking for LARCs, and it's currently sitting between 4 and 6%. So it is a slight increase, and that is specifically IUD requests. There is a little bit of backlog sometimes at a few services, and those services then funnel people through to us. And there's also a little bit of difficulty for some people sometimes accessing copper IUDs if that's their contraception of choice.
And we've just been joined by Elizabeth Kennedy. Hello again. Would you like to just say, because we've got some new attendees, where you're from and who you are, Elizabeth? It's lovely to see you.
Thank you. Sorry I'm late. Yes, I'm Elizabeth. I'm a GP. I work in Shepparton, Victoria. I have a background in sexual and reproductive health from Scotland, so. And yeah, and I do medical terminations and fit coils and implants.
Great, lovely to have you as always, Elizabeth.
Nice to see you. Thank you.
Now I might share the screen if I can. I hope you can see this. This is really not a didactic session. I'm just going to use the slides as like prompts, really. And so as we were saying, we were really just trying to look at, distilling what are the essential services. And I'm going to be taking notes, and Kath Hannon, who's an apology tonight, is going to listen to the recording and also take notes to get ideas from you all as we think about our strategy for 2022. So we're thinking about what are the essential components of a sexual and reproductive health service system to build a sustainable, skilled sexual and reproductive health workforce, which you are doing, all of you, at the moment, and doing incredibly well. One of the things we didn't mention, Carolyn, was the increase in the number of GP providers during the pandemic. That there has been a definite increase in GPs seeing the need and becoming providers. So the sort of things we'll look at are what are the, and I really want you all to chip in, what are the essential elements for developing a skilled and sustainable workforce? What's currently working in your own practices, whether they be a GP practice, a community practice, or a sexual and reproductive health hub, or indeed a hospital clinic. What's working for you, and what are the big barriers and challenges? What models of, if any, of support and supervision are available, whether formal or informal? I think you would regard our network as a formal community with the opportunity to have informal support discussions as well. And within our community, we have different models of supervision, which we'll talk about in a minute, and then opportunities for education and training and extending and the work and scope of practice of our staffs. So if we think of this first one, what are the essential elements? What do we really need for a sustainable, once we're starting a hub? And I'm just thinking that one of the teams who isn't here tonight is the Peninsula Health Group. They're one of the newer hubs, and they're actually opening their clinic next week. The nursing staff weren't able to come tonight because they were having a training session, but they are actually starting next week. So if we were thinking of advising a colleague about what are the things to think about when setting up a hub, and if we think about what's currently working, what's working well. So would any of you like to, before we go through my ideas, these are just all I use at the top of my head, what are the major things that you think are really essential? Louise, do you want to say anything about what are the key, or who are the key staff types that you really need?
Yeah, thanks, Patty. Yeah, I suppose one of the things that I would like to mention really is around at the very start, if somebody hasn't got the confidence or hasn't contacted, say, for example, 1-800-MY-OPTIONS, and they're just a cold call to your organisation, probably the most critical thing that we've found over the years is to have our front of house staff fairly well prepared, and even I suppose delegating some staff to have more learning in how to manage asking questions without asking questions, and to being really sensitive to people wanting some information, and really just reassuring people that they can just book an appointment, and ideally the nurse would contact them and take it from there. So really reducing any of the information gathering at the very start, and that seems to have been very effective for us, and word of mouth is that's where they come to. We've had lots of great feedback about our fantastic reception staff. We're very fortunate that we do have significantly our hub on one site, but we do have some clinicians working at another site, and certainly the wealth of collegial relationships and the ability to seek out each other and support each other with particularly, I suppose, sensitive or challenging situations has always been very valuable for us in our hub. At the moment, just for everybody's information, we have two two fully qualified GPs, one fairly new, who just finished her registrar training last year, and two registrars who are incredibly experienced, but still registrars who are finishing their training in the middle of 2022. So we have lots of young GPs, very enthusiastic, who have been very supportive of that. Probably the biggest important part of our services has been that we started having a nurse-led model before the hub was established. We had a female GP who really was very happy to prescribe, but she didn't have the time to do any of the preparation work. And that's been the major success, and that's how we've really managed to grow and expand our service. I'll let someone else talk now.
Louise,
oh, sorry.
Can I interrogate you, Louise, just a wee bit? Yeah, on
sure.
behalf of the rest of the team, because I am writing down these ideas, you know.
Okay.
How did you go about training the reception staff to be? You're really talking about people who are very sensitive listeners who pick up on the nuances. I'm just thinking of a 16-year-old ringing and putting the phone down because somebody was abrupt with them or something. So you've got to have a sensitive person who can triage with subtlety. So how do you train them?
Well, that's very true. So at the very beginning, when we had meetings about introducing medical abortions into our service, we included our reception staff, and they were there to probably ask questions of the clinicians about what do I say if this situation occurs, how do I manage that? And we're a large community health service, and our sexual and reproductive health hub sits within a primary care service where we have GPs who are doing GP registrar and major GPs and a large, GP practice. So we have, about 15 receptionists, full-time and part-time. So we've basically asked the senior executive for us to have staff who are willing and interested to be in that role and willing and interested to manage the phone calls. And then we just included them from day dot. And any new one that's come, our senior receptionist has actually trained the new receptionist. And we're just very, very fortunate that as our service has grown, our receptionists' sensitivity and understanding and knowledge has grown. And for a long time, we were seen as a youth service. So they for a long time, they were very apt at dealing with, if someone walks in and is very agitated or shy or crying, they would find a safe room and sit them there and get one of the nurses to come out and see them. So it's been probably years of experience, but certainly including those receptionists in the training that the nurses did in terms of dealing with sensitive situations is probably the main reason why it's been so successful. Yeah. I'll just make one point that what we've tried really hard is that when someone has when an organisation has a one number that you can get, like, 4 or 5 different reception sites, what we're trying to push for now is actually a number system within that set number, so that actually gets directed to us, because we've had multiple times where a very new receptionist has just been so overwhelmed, but they gave really inappropriate information, and our consumer was incredibly upset. So that's a real barrier for us. And if I'm talking about the best model, the model is actually having, separate numbers for separate services within an organisation. In a GP practice, that probably doesn't matter, but in a community health service like ours, I think that's really important.
Do you mean so press 1 for sexual health services if you're concerned about an STI, if you want to speak to a nurse for your results, those kinds of things.
Or just, if you want to speak to someone in the women's health hub or the the sexual health hub, it's just very generic. Yes.
So that's really interesting, and I think the point that you're really bringing out is that all of the staff are included in the training, and they're seen as equally important at every stage, from the receptionist right through to the prescriber and then the pharmacist. Does anybody else have any comments or questions of Louise?
We actually just have two options on our phone line, and one is, you know, the general one, and the second one is if you're ringing about abortion, it goes straight through to a nurse. We had really stable reception staff at the start when we were doing the service, and one of them actually developed some training, which was really good, but we've had quite a big turnover lately. I mean, we still do some training with the reception staff because inevitably they're going to get some sort of calls, but we felt it just really needed to go straight through to a nurse.
And there's a nurse there, Kathy, at the end of the line?
Not always. That's
all
the
right,
problem too. So they might get the answering machine, but yeah.
But it would be a nurse with experience in medical abortion would ring them back.
That's right. Yeah. Exactly. Yeah. All our nurses have that, so we've got a bit of luxury there.
Great. And Louise, one of the on this slide, Louise and everybody, but particularly Louise, if you wanted to comment on it a bit more. These are the things that everybody who couldn't come tonight, I kind of rang them and asked them what their experience of their service was. And again, this idea of task sharing and learning from other colleagues, having all of the colleagues trained together, the mix of early medical abortion and contraceptive services. And again, as you brought out, Louise, nurse-led models of care, whereby the majority of the assessment and follow-up is handled by the nurses or the nurse coordinator. Would you just like to elaborate on, you know, what how that would look, you know, and how much is follow-up and how much work goes into follow-up?
So I think this is the well known for those who've worked in the sector for a while, and particularly those who are getting to know the sector, is just how much work is done behind the scenes. And our model of care had always been to support the GP as a prescriber so that their workload wasn't onerous and it didn't take up too much of their working day, because we as Elise had mentioned, that there's a few other GPs in Bendigo who do provide and prescribe, and the wonderful GPs in Castlemaine. But by far we get most of the referrals from GPs within our region, and also from the Bendigo Hospital if people choose to have a medical abortion versus a surgical abortion, and the referral goes straight to the hospital clinic. So basically our nurse-led model is that the nurse either does a face-to-face visit. We have done telehealth via telephone consults for women in rural areas such as Echuca or Kerrang or Shepparton or somewhere like that, if they are coming to our service, to avoid them having to travel. Most of all the investigations that need to be done under the guidelines are organised by the nurse under the GP supervision, and all the education and information is either, you know, the booklets given out to them or emailed to them, whatever. So that whole kind of first assessment is managed by the nurse. And then one of the things we've learned over the last quite few years is to really try and be very clear with the consumer about the process. So even though they do see the GP either face-to-face or in sometimes telehealth, but basically when they get to that GP appointment, everything's done unless they've refused to do something, and then the GP will make that decision. So that really all the ducks are lined up. So the GP really just has to tick the boxes and go through the consent. One of the things we found with quite a few of our clients is that they actually were quite surprised about the process, about how to go to the pharmacy to take the medication, a bit confused about the timing, because it's such an emotional time when they come into the clinic for that first assessment. So we have developed a little bit of a tick sheet to give to them so that they can actually, you know, when they're home and about to go and get the first tablet, that they can actually, okay, then I'm going to do this and then I'm going to do that. And that's really important for some who, you know, for example, are going, have an event or have an evening. At the moment, they can actually go out to tea or something like that, and they forget that they actually may not be, you know, able to do that or feel well enough to do that. I suppose the other really critical thing is that we've been very fortunate that all our nurses are trained in implant insertion and removal. We've got 3 doctors trained in IUD insertions, and I was just doing some stats, and we've done, 78 IUDs in the last quarter. And so we're very proactive with our LARCs, and often they go away with a script and an appointment before they start the medical abortion process, so that they're booked in to have either an implant or an IUD inserted afterwards. All the follow-up is generally done by the nurse, ensuring that there's no issues in regards to their adverse events, etc. So it really is a collegial role, and we're very lucky. I know that there's GPs who don't have the capacity for practice nurses to do that. I wish they could, because then I think there probably would be a lot more GPs prescribing. Yeah, so I think that's about it in a nutshell.
And I think there are many other people here on the chat tonight that use a similar model. I think Elise, you really use a similar model with the GPs that you work with, don't you?
Yes,
Yeah.
very similar. I mean, recently I sent a woman to Dr. Mays in Castlemaine, and I suppose we just have to make sure that the women are aware when they go down to have the ultrasound that they may have to have a follow-up at Bendigo Health. There may not be a fetal pole, so yeah, it's just making sure they have all that information. And I'd love Louise to share her tick sheet, because that's probably something, I mean, we talk them through that, but I think that'd be lovely to send the women home with that, just to run through that with them. That would be really good, because yeah, it's so much information they've got to take in on the one day. When we do have women traveling rurally, like I've had a lot of women from Echuca and Rochester, so what we'll do, we'll often organise an appointment with myself for the choice-based counselling, go through all that with them, their options, once they have made their decision, and if they do opt for a medical. And sometimes we have spoken to them over the phone, and we're pretty clear on their decision prior to coming to see myself. We're able to do all the workup and everything in the clinic, and then they're able to make their way down to Castlemaine and have it all done in the one day. So it just makes it very streamlined.
Right.
Yeah, so we can sort of tailor that for them and have the ultrasound in the one day. But again, just, when they are early, just letting them know that they may have to have a repeat ultrasound.
And I guess the corollary of that is if they're too advanced.
Yes. Yeah.
That they may have to go to the hospital.
Yes.
I'm really glad you mentioned the tick sheet, because I was going to say if we could share the tick sheet, that can be uploaded onto the search toolbox, and anyone could access it there. So if you could, if that's one of the great advantages of this network, is that we do tend to share everything. So if you could send it to, would it be yourself, Sarab, that Louise would send it to, and we can pop it onto the toolbox? And hopefully you're all aware of the toolbox on the search website, where you can go in and all of our existent resources are all there. Ange Davidson, would you like to answer or add anything more about the task sharing and very well nurse-led model that you work within?
No, I think what Louise has said, I would very much second all of that, especially doing training and retraining and support and supervision of your reception sort of frontline staff. The other thing, so yeah, second all of that. The other two things that I would say is build really good relationships with your pharmacy, build really good relationships with your ultrasound providers.
Yeah.
And the other thing that we have done along the way is just we kind of strongly encourage, we used to almost insist that new registrars would either do the training, whether they didn't necessarily have to provide, but we wanted them to be able to do the training as an MTOP provider. But we strongly encourage all our new registrars to be a provider, so that we just build this base of providers when staff are sick and off. And so we started off with 1 GP, now we've got 6. So
All right. Yeah.
we're really lucky, and we support and encourage them to the best of our ability. But we're, like Louise, we're a nurse-led model. We're a funded nurse position, so that makes it a bit easier for us to do the bulk of the work and then just get the GPs to come in when they need to. But yeah, that's all I would add.
That's a really important part, is that if it's a nurse-funded model, then it becomes financially really viable, as well as making incredibly good sense to task share like that. And it really seemed to have been echoed. Your comments tonight, everybody, seem to be echoed by all the others that are already up and running. CoHealth in Laverton says exactly the same thing, and Siobhan Burke, being one of the doctors there who was often attends, but wasn't able to come tonight, she singled out all of those points as well, and added another point, which was a really good liaison with your nearest secondary or tertiary hospital with experienced backup. And so through this network, she's been introduced to one of our colleagues who works here, who is one of the O&G surgical team here in my clinic, who also works at Sunshine, and she has become the backup for any unusual questions. Can you administer it for this patient with these needs? If someone's COVID positive, what's the advice? Do we wait? How long do we wait? You know, if that's going to affect the gestational age, all of those sorts of things. And of course, in the rare case of a failed medical abortion, where it's an ongoing pregnancy, and that seems to be a recurrent worry of providers, that what are they going to do, how are they going to help the patient in that circumstance, and not wanting to throw them onto the you know, the heap of trying to find a provider quickly that they can afford. So that was one of the things that she said that works very well. And I think that Bendigo has a similar liaison, Ballarat has got similar liaison. Angie, do you have good relations with the hospital?
Yeah, we do. All our GPs, have great, they can ring all the obs-gynae at any point they need. And so that was something that we set up. That's in Wodonga. Kerry can probably speak for Wangaratta, but in Wodonga, all our GPs can ring at any time when they need advice or a secondary consult, or they've got any concerns.
Mm-hmm. So I've got all of those ideas down, thank you. The next thing was sort of the things that people are mentioning that are barriers, you know, that have come up. Retaining GPs in the hubs who will insert IUDs and provide early medical abortion, where there's, you know, quite a rapid turnover. I think Heather was mentioning, you know, that she's having some difficulty retaining a GP, but she's hoping to recruit someone else. And part of that is the inadequate funding for episodes of care, with the way that GPs are funded through MBS, and better remuneration in non-bulk billed clinics, etc. And we have talked about some of the opportunities around that, if we can lobby for more nurse-led models and funding for nurse-led models. So that's a very clear message I'm getting to take back to the department. Have any of you got anything to say about ways of retaining GPs, or I liked your model of, you know, benign coercion. Is that a term, Ange? Benign coercion of the keen young medical registrar, GP registrar, to at least explore what it takes to do MTOP, and then to support them to do it. You seem to have got a good cohort as a result of that. Does anybody else have any experience of how to support and maintain their GP, or indeed their nursing workforce? Anything that's worked, or any particular barriers? I'm just thinking, Anita, are you still there? I can't see you.
Yes, I am here.
Yeah. Hello again. Have you got anything to share about what sort of clinic works to support you as a GP? Or is it about the clinic, or is it about the community of other GPs, or?
Sorry, can you ask the question again, please?
We're just trying to work out, you know, because I'm trying to distill what are the essentials, you know, to keep a service running. And we were talking about ways of trying to support new GPs coming into the hubs to become providers. You're someone who's moved around a little bit. Is there anything that is essential in the clinic that you work in to support you to be a provider? Or is it more about your external community partnerships like this? Or some of the GPs I know do a lot of supporting of each other on MTOP Doctors Down Under, you know, all sorts of informal ways of supporting each other. Just wondered if you wanted to say anything about what works for you, because you seem to work in a slightly different methodology.
Yes. Thank you. Look, at the moment, I have only worked in private, and whilst it's just how it's landed for me. So whilst I'm at Peninsula Health, I've known Kathy Halmarick for a long time, who's starting, and Nikki Martin, who's starting the Peninsula Hub out of Frankston, or providing MTOP services through Frankston. And I've put my hand up in public to say that I'd be very happy to be a part of that. But I guess, and it's taken years, as you probably know, Patty, I think we spoke a few years ago, and it's taken Peninsula Health this long to get it up and running. So I think they'll see how they go. My hand is still up to provide a service in public. In terms of support, I've found this is the difficult thing about private work, is that you're very much your own person, and it's about how much you're willing to extend networks outside. I didn't even know this little hub existed, that this network existed. It wasn't until I saw something through Sphere or Medcast and Sphere, I think, and I saw Kathy and she'd listed this. So yes, I do talk to medical students, and there's definitely an interest in more people wanting to do it. But it's interesting, on the peninsula, it's a very small community, well, reasonably small community of doctors. I heard a gynae say a couple of years ago, I'm happy for you to send me one or two, like more complex patients, but I don't want to become known as the abortion doctor, is what they said. And I know some of the GPs down here who are mostly doing women's health tend to be doing more psychological medicine in the community or antenatal shared care. So they have a lot of experience with pregnancy, and they just don't get large numbers of abortion, patients seeking abortion. Does that make sense?
Yeah, it does. And, you know, one of the themes that comes across in a lot of the presentations, both from networks such as this, but also from international conferences, and I'm thinking particularly of the NHS model that was developed by BPAS, particularly in response to the pandemic, that there's something about having a high volume clinic, you know, or having a hub, even if you don't think it is high volume, compared to a GP who does 1 or 2 a month. Seeing 5 to 6 a week is high volume, and you get the pattern recognition. You get, out of those 6, you'll get about 1 out of 6 has the annoying bleeding pattern, which drives them to distraction and us to anxiety states sometimes. And you might get, after 100 cases, you might get 1 that was a failed, or you might get 2 that needed to go to hospital for a curette. But if you're a GP on your own, Anita, and your first 2 have problematic bleeding, it puts you off. But if you're working in a team and they go, yeah, you get that, but it'll be okay. And we, you know, and Louise tells you that at follow-up, the patient's actually okay. Everybody learns a lot quicker with that high volume methodology. So I think that it's a really important point that you're bringing across, that it is harder for those who are only doing a few. I'll just move on because I'm sorry.
I just wanted to add one thing to that.
Yeah.
A very competent GP down here said to me once, she was liaising with me, the patient, I had seen her patient in private who went back to her to have it with her. But this particular GP, the reason why I hadn't proceeded is because it was still technically a PUL. There was no CRL or yolk sac. So I'd counseled the woman and said, look, it's not intrauterine at this stage. It most likely will be, but we can't exclude ectopic and la la la. And the GP gave her the medication. And when I went through, I said, oh, did you order another scan and confirm it was an intrauterine pregnancy? And she said, what do you mean? And I said, well, did you do another scan that showed a yolk sac or a CRL? And she said, no. So I think there's a lot of misinformation or perhaps lack of understanding too, Patty, so that you don't get that if you're not doing a lot of it.
Exactly. Yeah. And yeah, I agree completely. So just because I'm aware of the time, I just wanted to mention a few of the other things that have come up, that some of the hubs have applied for and got ultrasounds. Others would like one. I know that Kathy Hilmarik's hoping to get one. Bendigo has one, and so has CoHealth. And it's whether or not it's a helpful thing, or if it becomes an albatross around your neck, because then you're not allowed to use the blooming thing, and need to organize training for it. Mm-hmm. So does anybody want to make a comment about that, and how we could, you know, why did you want it? Presumably it's because it's hard to get ultrasounds, and it was really blooming handy if you've got one in your rooms. Does anybody want to comment?
Patty, we had an ultrasound to start with, and a couple of us did.
Who's that? Is that Kathy?
Oh, it's Kathy, sorry.
Yeah.
Yeah.
No, that's fine. It's just the funny thing when you're not in the room, you can't tell who's talking.
A couple of us did training, but we actually found, and one of the problems was it took so long for family planning to get up and going that the training was temporarily quite a while before. But there was no one looking over our shoulder, and we stopped using it in the end. We were finding most people were coming in with an ultrasound, and we'd gotten to April one year and we'd only done 7 ultrasounds, and we'd missed a cervical ectopic, and we just sort of thought it was the blind leading the blind. We got better, but we really needed some input from someone, and I think that's one of the things that might be lacking for some services if they want to use ultrasound.
Anybody else want to comment on that as to how you might get your training, or any of the others? I don't know if Sam's still on, but Sam would be able to access a scan, I imagine, in his rooms if he's still there. He may be cycling again. Yeah, but I'm pretty sure he's got access to an ultrasound, which then saves all of that hassle and time.
Hi, Patty.
Oh, you're there.
Sorry, it just took me a minute to pull over. Yeah, no, ultrasound's really handy in that it saves women time and visits.
Yeah.
And provides confidentiality, because they don't then have to go through that uncomfortable conversation of the ultrasonographer telling them congratulations or telling them why they're having a scan. So it certainly can be really useful. We suffer from the same problem as everyone else, that we are still using outdated ultrasound equipment, and I think the ultrasound I use on most days we borrow from the medical students, and both the machines at the hospital and the clinic are more than 10 years old. So, you know, funding's an issue. There is for rural abortion providers. I appreciate that some of our members of the group are from metro and some are from rural areas, but for rural providers, there are grants that can be accessed for nurses and doctors and other allied health practitioners to access training on bursaries through the Rural Workforce Agency of Victoria. So that's something that potentially people can use for funding to pay for ultrasound courses. And then there are courses I've noticed in early pregnancy ultrasound for targeted MTOP available through providers in Victoria, which is good. But again, like it does sound like it would be tricky if you didn't have somebody else there who you can ask.
Yeah, and again, it becomes that whole thing of, you know, doing lots. You know,
Yeah.
there's a critical number that you need to get under your belt, isn't there? Yeah.
I think it's really interesting. If I can just add
Sorry.
comments, can I just add some comments to the
Please.
conversation
Yeah,
about how do
about.
you
Yeah.
how do you get GPs into a service? I think in lots of areas, I think general practice work is quite hard, and a lot of GPs find GP work a bit of a slog and would like to do things on other days. So for a lot of GPs, working in a sexual health clinic would be quite attractive, but maybe those models haven't been established, so they don't necessarily know about the positions, and I don't know how they are funded. Like, you know, if as a GP you were going to give up a day in general practice, you wouldn't want that to cost you money to go and work somewhere else. You know, you'd want to know that you were being paid at least, you know, sort of somewhere comparable to what you would be making in private practice. But I think in a lot of areas, and we've spoken to like colleagues from areas of the states where there are lots of GP obstetricians in Echuca and Wangaratta and Albury, down on the peninsula, maybe a little bit less so in terms of like procedural GPOs, but there's certainly lots of people around who could do this kind of work. But I just wonder if maybe people don't know that there are positions potentially available, and I don't know what sort of funding is available for those GPs. But I think those would be barriers to starting to recruiting and retaining GPs.
Yeah, and I think Bendigo has mentioned that, you know, about the loss of income if you're working in a sexual and reproductive health clinic for some GPs. I just wanted to very quickly mention that with regard to the ultrasound issue, that the very important work that BPAS has released as a result of the work they did during the pandemic in Britain, they have a database of their study involved 52,000 women having early medical abortion. And they went from a model of everybody being scanned in the clinic and getting their medicines in the clinics to everybody having their medicines posted out to them, and 90% of them not having a scan. And so they developed a no scan model, and it was a very, very well triaged model. And so it was replicated in high volume clinics. So we're talking about clinics that might have 100, 150 patients a week, and they might have 4 to 5 nursing staff doing that triage. And they had a very well developed system of assessing whether the woman was accurate about had accurate knowledge about approximately how pregnant she was. So they went into how many months of regular periods they had, and they had to have had at least 4 months of regular periods prior to the absence of their periods. They would then decide who didn't need to have it, and no past history of an ectopic, etc. And their rate of missing ectopics was exactly the same as when they scanned everybody. So it was a very, very safe system. Now, I am not saying tonight, do this at home, kids. I'm not saying that we are ready to do this at home at all, because we don't have those systems. We don't have those big high volume clinics where everybody's running the same protocol, you know, and we might get someone like Anita's colleague who didn't quite understand why we were screening for a query ectopic. You know, so some people did need scans, but the vast majority, if they're very early in pregnancy and have a really good system of follow-up, and all of those women had a mailed out low sensitivity pregnancy test and a phone follow-up at a week or 2 weeks, and it was a highly safe system. So what I'm just saying is that given that we have this problem in Australia of trying to get competency in ultrasound, that it might be a pilot model that we could do, and I'd be really interested in looking at this in one of our high volume hubs. So to be continued as a conversation, but just to say that the knowledge is improving all the time about how we can run this kind of a service for women and pregnant people and make it really patient-centered. And then the final thing I wanted to say is sort of the good news stuff is that you were talking about having these great young registrars who are really keen. There's another group of registrars who I think that we could plunder to use in our sexual and reproductive health hubs. And that is the late stage trainees in obstetrics and gynecology who have an interest in sexual and reproductive health. The college and the interest group that I've been involved in the college over the last 8 years has run this thing called an advanced training module. And that's for ONG trainees that want to become abortion care providers and contraceptive care providers. And we take them in their 5th or 6th year of training, and we teach them a lot of advanced skills, both surgically and with medical abortion. And then the idea is that they will go out to other public and private services, ECDNEAL being one of those that we were just talking about. But the college has now moved to accept an idea that we've been floating for about 6 years, and that's to completely kind of copy what they do in Britain. And Elizabeth might know about this. In Britain, they have a faculty of sexual and reproductive health, which is part of the College of ONG, and the trainees can choose in their final 2 years to diverge and go into sexual and reproductive health. So they're generalists in ONG, but they don't carry on doing that training. So they don't become endoscopists or, pelvic floor surgeons. They become sexual and reproductive health surgeons. And at the moment, we're working on that curriculum, and it's going to have lots of, within the 2 years, it's going to have modules. And it strikes me that a rotation to a hub would be a fabulous model where it's a win-win for both. So for example, if one of the trainees went to Wodonga for 3 months and worked in the hub there, they would, or went to Laverton and worked in the hub there, or went to Frankston, or to Peninsula Health, they would get that really interesting, diverse demographic experience. They would get high volume work, but they would also bring with them to share and teach while they were there quite advanced IUD insertion skills, because they're in their 5th and 6th year of training, and ultrasound training, so that they could then teach, they could be the teacher who teaches the teacher and teach the next level of nursing or medical staff in the hubs. So I think we're at the point where we can advocate with the Department of Health with regard to new and different ways of training our staff to make it a more sustainable service, and think about the hubs being the creative learning and leadership potential. So we, as the network, and myself and Kath in our role as clinical advocates in the Clinical Champions group, are going to go back to another round of funding and negotiation with the Department of Health for next year. The department recently expressed a great deal of support for using the model of the hubs to be the training and leadership potential, and that rather than developing more and more hubs, that they would put hopefully money into extending the scope of practice and the amount of clerical staff that could be made available within the clinics to better free up nursing time. So if we can see ourselves as a network as quite a powerful advocacy group, and the stuff that you fed back to me tonight is something that there's similar themes, but you've all given me quite a bit of detail. And I think that with my work in the college, we're hoping that by 2023, we'll have our first 2-year trainee doing the sexual and reproductive health care training. And that we might, within the next 10 years, see these kind of registrars also coming out to the clinics and hubs, and bringing, they would also rotate through clinics like menopause, sexual health clinics, sexual assault clinics, those sorts of things. So they become a real expert in this area. So I think there's quite a bit of good news from that. And I want to thank you all for the work that you do. And it's invaluable work, but the work you do in these network meetings is also really important, because you're feeding back up and to search how we can better advocate for you. And I don't know if you all know about Sphere. We were going to have a little presentation from someone from Sphere. Sphere is the network of community practice started by Daniel Matz's group to really do research and development in the area of improving a community of practice for early medical abortion and LARC insertion. And it's really gaining momentum. So hopefully, Sarah, we could have that presentation at the next meeting.
Yeah,
unless anyone's got pressing further comments, I'm just aware I've gone 10 minutes over tonight, so I do apologize. Was there anybody who wanted to either ask a question or add a pearl of wisdom?
I think Carrie from Children by Choice had a question in the chat about anyone offering VMA.
Anyone?
Carrie,
yeah, sorry. Hi all. I know I'm a bit out of place here. But people were thinking I could come along and listen in just to see what you're all doing. We've been talking to some practitioners up in Queensland who've been providing VMA and doing some work putting together a position statement. So we were really just sort of curious as to whether anyone is doing that or thinking about doing it, I guess.
We're doing it, Carrie, in FPV, but I've found that most of our other family planning colleagues have stopped doing it, which just sort of made me feel a little bit more anxious about it. But yeah, but
sorry, I mustn't have heard. Providing what?
VMA.
Very early medication abortion without ultrasound.
Yeah,
we're doing an ultrasound. Yeah.
Yeah.
That's the Austrian model, which works really, really well again in those sort of high volume clinics. Yeah. And so are they doing it in Queensland?
There are lone providers doing it.
Yeah.
And our one at True, which is a big sexual health organisation, has protocols for it and refers to it. But it's not widespread by any means.
I think it's very exciting. It's very patient orientated, and it's probably the future, is what I would say about it. But it does require a great deal more concerted effort with regard to follow-up, or a great deal more impetus put on the patient. And it does, my reading of it and experience with it is that it works really well in societies where services are very, what's the word? They're very siloed, so that sexual and reproductive health services are always run through certain types of clinics. And it's not lots of different providers providing the same thing, but you go for the VMA to the family planning clinic, and that's the only place you get it, and they're all high volume clinics. So those practitioners are really used to it, and the only place you get follow-up would be going back there a week later, kind of thing. Yeah, but I thought I think it's very exciting. What was your experience with it, Kathy?
Well, we do them. It's selected. Like, we're fairly restrictive in who we do them with, but we do them, and it's usually just because the client really wants it, and they understand what we're saying, and they don't have any risk factors. Yeah.
Thank you. Thanks very much.
Okay, all. Well, we'll say good night and all the best for the rest of the year. Sarah, have we established when our next meeting is?
We haven't yet, but we'll do that, and we'll send a message to the group.
Yeah, so it'll be in the early new year, probably February, I imagine. Yeah. So thank you all for coming, and please check out the Search website and the Toolbox Hub, because there's a lot of information there. And if you could share, Louise, that tick box, we'll share it with the rest of the group. Bye for now.
Thank you. Bye.